But I have a method that I used to use in the labs, which is called laugh, right? For Filipinos, it's like, ha ha ha, that's laugh. I'm laughing at you. Sorry, I gotta hold my daddy jokes every now and then. But laugh is, you check your leak. When leak is controlled, then you move forward in addressing your apneas, whatever the apnea is, before you make any changes in your pressure. So I always follow that algorithm. Otherwise, if I don't control my leak, I'm going to take the patient, not the patient's mouth, the patient's mask. All right, finishing up here. So we all know the optimal titration, which is to reach a normal AHI and have the patient on rapid for 15 minutes, right? Is it always possible?
No.
No. Especially if you have a patient that had an AHI of 100, 150, 80. No, it's very difficult to get them under 5. But the most important thing is that when we look into algorithms that already exist on the devices, we have to remember that these algorithms are not independent. They are based on our skill level. So part of the algorithm is our skill level. Knowing when and how to approach the patient, aggressiveness or conservatively. Do they have tendencies to go central? Then you go a little bit more conservative. So there's many other parts here. This discussion is not for a 50-minute talk, but my takeaway for you is that when you talk about algorithms, create an algorithm for your titration, but always include the patient's response and the control of leak. I would love to talk more, but I'm getting kicked out now. Do we have any questions? Yes.
Will you talk about IVAPS or will you?
Oh, Robin, can I talk about IVAPS a little bit? 2 minutes. Okay.
I'm the taskmaster.
Gotcha. So VAPS, when it comes to volume assured pressure support, you have 2 types, right? One, they both protect the patient's volume. And one monitors tidal volume, right, per breath. The other one monitors alveolar ventilation, which is the tidal volume minus dead space. But the key I want you to remember when it comes to VAPS titration is the backup rate. For those using TX, the IVAPS TX, when the doctor writes a backup rate of 15, it's not 15. You take 2/3 of that. 2/3. As a tech, when you see 15, take 2/3. That's your backup rate for VAPS. Otherwise, you're going to be making that titration aggressive. That VAPS response will be too aggressive. The way the intelligent backup rate is designed is that it allows for a patient to have their own range in their rate. So if you put 15, it's going to be too high. It's always 2/3 of the actual patient's rate. Yes?
So then should we put 10 if we want 15?
Yeah.
Or should we put 15 because then if we put 10, I can go 7?
If you are using TX, put 10 because it will confuse the tech. If your goal is 15, put 10.
Okay.
Yeah, it's because the way the backup rate works for a IVAPS TX. It's not a black and white backup rate. It's an intelligent backup rate.